I invite Dr Aruna Chelliah, my friend. She needs no introduction, energetic and enthusiastic. She did a with me in Madurai Medical College, MD in Internal Medicine from New York, USA, Fellowship in Diabetes, Metabolism and Endocrinology from University of New Mexico, USA, and she is an American board certified diabetologist, metabolism and endocrinology, consultant and division chief, WellSpan Endocrinology, WellSpan Health York, Pennsylvania, and attending physician, York Hospital, USA. Then the topic is 45-year-old female presenting with severe hot flushes. A menopausal topic. This is the most common symptom, a nagging symptom, and over to you, Aruna, finally.
Another informal introduction. Aruna is the daughter of my professor, Professor Dr. Chelliah. I worked as assistant professor under him for nearly 6-7 years. And, Aruna was in my unit as an undergraduate. So, again, a long association.
Thank you for your kind introduction. Sure, it's really a pleasure to have both my professors here today. Thank you. And definitely it's a pleasure to be with my friend who is chairing this session. Thank you. So for the last day, and I really want to thank every one of you standing here, last man standing for a long day. Hopefully this is a good session that you have enjoyed. So 45-year-old female with severe hot flushes or hot flashes, goes with which country you are. So I'll start with the case presentation. 52-year fairly healthy female. She is feeling very hot. She has this flush, starts from the lower part of her body. It spreads over her shoulder, neck, and face, followed by profuse sweating, and finally she feels very cold and chilly. This happens initially intermittently over several years, but then of late it's almost daily, multiple episodes, worse at night where she wakes up finding her bed sheets and pillow covers are wet. Now, when asked further, she denied any symptoms like palpitations, tremors, chest pain, or dizziness. But one thing, she was very frustrated. She used to have a very good sleep cycle. Unfortunately, that's no more. She's unable to fall asleep. She's watching the clock. And even if she falls asleep, it's very short duration. She wakes up. So she's not well rested of late. It's going on for almost 6 months. And she also notices some physical changes, very dry vagina, burning, poor libido, hair loss, dryness of her eyes, mouth, and skin. Nothing else changed. She's not on any medications. She experiences generally aches and pains. Pretty much she feels like an old lady. And the most frustrating part, she's gaining weight in spite of having a regular exercise regimen, and she's eating health. And of course, her husband is thinking, whom am I married? This girl is so forgetful and she's extremely irritable and snappy. She's not the woman I married. And when you inquire about her menstrual cycle, she says it's now every 3 or 4 months. I don't know. Sometimes the flow is heavy, sometimes it's light. So as Dr. Adlin said, I'll come back to the case again at the end and we'll go with as she did, we'll start with menopause. There are differential diagnoses from endocrine point of view, but we will jump into the topic directly. So what is menopause? Where this name came from? It's from the Greek word. So pauses means pause, and it means the month. The monthly event that happens in a woman's reproductive life that comes to an end completely. So it's a natural and permanent cessation of menses resulting from estrogen deficiency. This is not associated with any pathological process. So amenorrhea should be lasting for 12 months from the last menstrual period of a woman's reproductive age, which marks the end of her reproductive age and childbearing time. So why this is so important? Because I just was discussing with Dr. Gayatri. She said nobody comes. Women don't come for treatment. Why? It is a very important topic because women need to know they have to approach the doctor. They don't have to suffer with menopausal symptoms because it does have physiological bearings and long-term complications. So this usually occurs between the age of 45 and 56. And a mean menopausal age in Indian women is lower, it's 48 years, and whereas in Western countries is 51 years. Now, the most important thing, 30 or 40 years ago or 70 years ago, women achieved menopause. Many people died even before that, or they died right immediately they went through their menopause. But now, women live longer. That means when she chooses to have her menstrual cycle, she's going to live for 30 years post-menopausal phase of her life. That's 40% of her lives. So why that is so important? This is very important because it has a profound public health care issues. Because 401 million women in India is expected to be for 30 years in post-menopausal phase. That means they are going to develop the chronic complications of menopause. Hypertension, heart disease, osteoporosis, declining quality of life. They can be bedridden in case of fracture. This is going to skyrocket. So objective today here is we are going to see the basic physiology and etiology, learn about symptoms and physiological changes, and what are the stages of menopause and diagnosis and complications and some treatment options management. I'm not going to go into the controversies today. So, and we will see why this is an interdisciplinary approach is needed for menopausal management. So aging. Menopause is a natural process again. So aging, you see a reduction in number of the granulocyst cells from the ovaries, reduction in the levels of the hormones, inhibins and estradiol comes down, loss of inhibition on gonadotropins, so your FSH, LH levels are increased, disturbances in the hypothalamus, pituitary, ovarian axis. So this leads to failure in the development of endometrium, irregular menstrual cycle. Eventually it gets atrophy and you don't get periods anymore. So this is a beautiful, I love this graph, which really shows how far the way the hormones are secreted and when we start experiencing menopause. So estradiol is the most important active estrogen, and you can see from approximately up to age of 50, it is quite highly secreted, then it starts gradually down and really low for rest of the life. And same thing, simultaneously, you see the FSH levels crossing and it's high. So here's the description transition of menopausal phase. So when menopause is natural, that means are there unnatural causes or induced causes? True. So if natural causes where there are ovarian reserves are going down, your hormone levels going down, triggering menopause, whereas induced menopause could be surgical or medical. So surgical, like bilateral oophorectomy or chemotherapy, hormone therapy, or radiotherapy. So, and diseases, other things are involved. So now, induced menopause can we be risk for early menopause? Definitely. There are certain causes we have found out that can put you in early menopause. Unhealthy lifestyle habits, family history. Most of women we follow are mothers. And chromosomal abnormalities, reproductive history, or autoimmune conditions. Now, what are the symptoms that pretty much from head to foot? So you're not the women you are anymore, believe me. So, because the topic was given to me, who can better explain than a woman who's undergoing menopause, right? That's me. So, hot flushes, you do it, night sweats, difficulty in sleeping, emotional changes. Well, all these are already said. What are the ways? You won't believe. Brain fog. Yes, this morning, I'm like trying to find words when I'm doing the MC. I'm like completely trying to recall people's name. Thinning of hair, smaller breasts, you're no more the women you are, and nothing fits. If you really look into it, this symptomatology, this study came from India. 45% women complained of hot flashes, 33% night sweats. So vasomotor symptoms tops the list. And then finally, you see the other changes. So practically, system-wise, you can go through it. Central nervous system, skin changes, metabolic changes, musculoskeletal system, urogenital, and sexual dysfunction. So from psychological to physiological, it is no more you. The estrogen that defined you as a woman, when it leaves you, you don't know whom you are anymore. So can we score this? Yes, we do have scoring systems. It's really awesome. And there are several scoring systems, and this is one easy Australian one, but pretty much they all follow 0 to 4 intensity. So why do we need to score these symptoms? It's really, actually, we need to get this scoring system awareness to the women in menopausal phase, because they need to know when to seek treatment, mild, moderate, or severe. And if it's severe, they don't have to suffer through it. Just because it's natural, we don't have to suffer. It is cultural, we don't have to suffer through this. No, we do have relief, and we can seek help. We can lead a healthy life. And the symptom scoring sheet also helps us to make sure when we treat the patient, whether they're improving or not, your treatment is improving or not. Every 3 months you can do, or every monthly scoring system, you can help use this to evaluate. So the way, again, staging, it's very important to know the staging. We call something called, there are 4 stages. Premenopause. Premenopause is from the age of menarche to approximately around age 35 to 45, where you get the regular periods day in and day out, I mean monthly, I would say. Then slowly irregular, right, it starts, and your irregular periods comes anywhere from age of 40 to 50. Then finally one fine day, the patient finds she did not have a period for the last several months. That could be 12 months. When it says 12 months from the last period, then it is menopause. So if she had been in the menopause phase, then finally she moves into postmenopause or senescence, where she is permanently menopause for the rest of her life. Now, there are 2 other phases that you should be knowing here. One is the premature ovarian insufficiency, or POI or POF, we call, where the lady becomes prematurely menopause before the age of 40. It affects 1 in 100 women, and it does have severe consequences, health consequences. And early menopause, so average in Indians, we go through menopause around 48 years, and 51 years in Western countries. Anyone goes between the age of 40 to 45, that's also early menopause. Again, as I said, remember, once a lady, she enters the postmenopausal phase, then she's going to be there for 30 plus years of postmenopausal phase in her life. So a premature menopause women, many causes are, first, endocrinological wise, always autoimmune disorders we are looking at, or genetic causes, infection. It could be familial too, or induced chemotherapy, radiotherapy, surgical causes. So I do see a lot of women coming and telling me at a younger age undergoing bilateral oophorectomy here in India. It is higher, the incidence, compared to in the United States. It's really worrisome, but a lot of reasons. Most of the time it is endometriosis is the reason. But I don't also see the reason for why the patient had to undergo bilateral oophorectomy, a young patient. So the signs and symptoms, again, the same thing, but in a surgical menopause, the symptoms are very severe, and it could be very, very disturbing for the patient. And long-term effects, again, this lady is going to be in longer in a postmenopausal phase, that she can develop infertility. She is now high risk for heart disease. She has urogenital complications, and of course infertility. If she ever wants to have another child, she can never have. So treatment, again, we'll come to treatment later. Diagnosis, do we have any particular test? Does all postmenopausal or menopausal women need a test? Actually, none. You don't need. It's a clinical presentation. 12 months, retrospective diagnosis, 12 months of amenorrhea, objective sensitive marker, that is irregular cycles. There's no independent biological marker. There's no need for routine testing. You can as well start treating the symptoms rather. So the diagnosis, if you really want to do a diagnosis, if the patient wants to know, I underwent hysterectomy at a young age, I don't know whether in menopause or not, but I'm having all these symptoms, and she's not sure whether her ovaries are intact or was taken out. Yes, you can go ahead and do an FSH level. If the patient wants to know, whether she can get pregnant, AMH, you can do. So there are very few places or very few scenarios that you really need laboratory evidence. So postmenopausal health ailments in India, as I said, already I listed, it's from head to foot: cardiovascular complications, metabolic, genitourinary, musculoskeletal, psychiatry, pretty much every specialist and primary care physician in this hall, pretty much you will be seeing these women. So first, most important thing is cardiovascular. So very important, because once the estrogen protection is gone, the woman is high risk and she's equivalent to a man for having heart attack. And the age of premature menopause, women between the age of 40 and 50 can have a high risk. Already there is a incidence of high risk for heart attack, MI, between the age of 40 and 50 in women. And women do not present in a classical way for their myocardial infarction. And if you see in the left-hand corner, the indigenous South Asian and African women, Southeast Asian, that is us, we are one of the biggest risks for heart disease. So we Indian women are very high risk for heart disease, and we do hear news, and some of our colleagues of late, we lost them for massive MI. And so how do we risk stratify? So this is important. Menopause is important. It's important for the patient to know, I have to go to the physician. It's an obstetrician, gynecologist, a primary care physician, or endocrinologist, doesn't matter, and discuss about this, because they need to be risk stratified for heart disease. So you have the assessing after menopause, or even during menopause, whether, because either a physical history, pregnancy history, whether they had metabolic profiles, disorders, then markers, labs you can use to risk stratify them. So how does estrogen deficiency decline causes atherosclerosis and puts us at higher risk? So you can obviously see menopause and aging, because the physical disability sets in with sarcopenia, loss of significant muscle mass is noted, obesity sets in. And definitely when obesity sets in, with estrogen release, decrease, you can see visceral adiposity, dyslipidemia, insulin resistance. Again, it all again goes towards the metabolic disorders, MASH or NASH, everything develops. On the left side, you can see the even vascular changes are noted. And oxidative stress and vascular proliferation happens, inflammation. So it's very important that women are educated, not after the menopause to come or in the postmenopausal phase, but even before, during even the premenopausal phase, they have to be aware when they start the perimenopausal symptoms, get checked. So usual treatment, of course, for any disorders in life now, metabolic disorders, lifestyle changes, no matter what. Exercise, healthy diet, appropriate fluid intake, sleep. Yes, all this is important. The second most complication, the silent epidemic in India that's going on and is going to get very worse, and across the globe also, is osteoporosis, fragility fractures. As I said again, remember 30 years in a postmenopausal woman, that woman is going to lose height, she's going to have severe scoliosis, a hip fracture, and the data shows anywhere around within 6 to 9 months of a hip fracture, the mortality rate is very high. So clearly, you can see the estrogen decrease and the bone loss starts. And the peak bone loss, this is very important clinical point. The first 2 years after she achieves menopause, the rate of bone loss is extremely high. Within 2 years, the lady can go from minus 0.5 to minus 2.5 in the Z-scores. It's very important, especially if she has higher risk factors for osteoporosis. It's important this patient knows this and takes appropriate steps to prevent osteoporosis. And there's going to be like 1 in 3 women are going to have vertebral fractures, and annually across the globe, 8.9 million fractures. That is 1 in every 3 seconds. So also you not only lose the bones and you're developing osteoporosis, well, we are losing our teeth also here. When you lose your teeth, I have seen this happening to my family members, the nutrition goes down. It only gets worse. They're not eating, unable to eat, the dentures are not fitting, and overall they decline further. So it's again very important why we need to make this as an awareness program in your practice, and especially the obstetrician gynecologists are the first area where women touch down. In India especially, that is where the most often I see women are going. So Are there any risk factors? Osteoporosis, I'm not going to go major thing. Yes, there are modifiable, non-modifiable risk factors. The guidelines is more important, which is not here in force. So all women 65 years and older, regardless of risk factor, should have a bone density done. And postmenopausal women with one or more risk factor for osteoporosis other than menopause should have a DEXA done. All postmenopausal women with fracture should have a DEXA done. So again, this is not being implemented. And fragility fractures are very high, and secondary causes needs to be ruled out. And Indian females are very high risk. And once you risk stratify the patient, you can commence the treatment. So a low risk patient, just lifestyle changes and vitamin D calcium replacement. For high risk patient, definitely anti-resorptive therapy needs to be given, and you have to also teach the patient regarding fall and fracture preventions. Then very high risk fractures, you have to give anabolic agents. So the final topic for this day that we all waited, no more we call hormone replacement therapy, it's menopausal hormone therapy, MHT. So we do start with classification first, whether is this woman needs a hormone replacement or HRT, I'm so used to saying that, is whether the woman has symptoms or no symptoms. That's the first thing you go through this. So if no symptoms, then just lifestyle changes, or even if the patient is not ready for HRT, lifestyle changes. Now, second, whether the patient has intact uterus or no uterus. So if the patient has intact uterus and definitely there's 12 months menopause is confirmed, then you can have the hormone replacement therapy commencing. There are different ways to do it, how long to do it. If there's no uterus, then you have to make sure the patient does not have endometriosis, because if you are going to give estrogen, that can, if there is endometrial seeding, that can worsen it. So it's very important, you need to know again, continuous therapy with low-dose HRT can be commenced. So what are the various preparations that are available? Many preparations are available, doses are available. Again, I'm not an expert in this because I diagnose and send the patients off to my colleagues across the stage here. And oral transdermal, there are a few exceptions. Transdermal is supposed to have bypass the first phase through your liver. It has some protective effects, and it is accepted, more acceptable by many women compared to oral replacements. The window of opportunity, when do you do it? This is the time, the middle time. So when the patient is going through from the first 10 years, 10 to 12 years, that is below the age of 60, that is the area that you do hormone replacement therapy. The women gets the maximum benefit. Beyond that, she is very high risk for harmful effects, especially atherosclerotic disease. Contraindications, we have to rule out all these: breast cancers, endometrial cancers, or any heart disease, DVTs, before you start. Duration, this is again a controversial area. We used to say the lowest dose for the shortest period of time, but it's no more. This is, I get it from AGP, they're saying no more. It depends on the patient and the doctor. So it could be whatever it is that helps her with her lifestyle, as long as she doesn't have any risk factors and she feels comfortable. So now, non-hormonal therapies for all those vasomotor symptoms, yes, we do have SSRIs, SNRIs, and we do have anticonvulsants, pregabalin, gabapentin for pain syndromes. Clonidine is very effective for vasomotor symptoms. You have clonidine patch we use, and it's very helpful for the patient. So, and we do have SERMs. SERMs also is a non-hormonal, the selective estrogen modulators. This is something that is also really good as long as the patient does not have DVT history, but it also has a positive effect on the bone. So it's double, two things you get out of by selecting this one. The new one on board is tibolone. So it is a selective tissue estrogenic activity regulator. I don't know what it is, I've never used it, but it says has estrogenic, progesterone, and androgenic properties. And definitely it is very effective in a very low dose, as low as 1.25. It should be prescribed. That's the only thing, grade A, 1 year after amenorrhea. That's the most important thing. Significant improvement in mood and libido, that is grade B, and it does help with the vasomotor symptoms and especially improves urogenital atrophy. So some of the side effects, the common side effects are all given, but usually patients, most of them are really tolerating well. Contraindications, definitely breast cancer or undiagnosed vaginal bleeding, severe liver or hepatic disease, heart disease, or hypersensitivity. So pros and cons of benefits, definitely. It elevates the symptom. It makes you whom you are by giving back the hormone, right? Osteoporosis prevention, cardiovascular health, and cognitive benefits, and definitely decrease in Alzheimer's and improve quality of life. Obviously, we have to worry about increased risk of certain cancers, breast cancers and endometrial cancers, heart disease, long-term considerations. We have to really know. Nobody has the long-term data, but right now there are some studies that are with Women's Health Initiative in a selected few patients without any major contraindications or risk factors. It's very helpful. So these are the gynecological and preventative measures that we have to ask our well women visit. So in US, it's called well women visit. Yearly, we have to go get everything done, age appropriate mammogram, colonoscopies, pap smear, pelvic exam. So it's important among that also bone and metabolic disorders. So it is in menopause is a time of change for the women, provides an opportunity for us to assess and promote health for these women. So topical vaginal estrogens will be helpful to relieve like dry vagina or dyspareunia. Now, what do you mean by menopause empowerment? Culturally, we women are inhibited. It's not just here, abroad also. A very hot, flushed patient with a disability or memory issues, she's in the CEO position, unable to make decisions, or she doesn't have any, absolutely 1 or 2 hours of sleep, she's unable to, can she give that as an excuse, being a CEO or a managerial position, or no matter what, where she is? We need to have cognizant, and these women need to be provided workplace, place that they can come and work in spite of all these symptoms, supportive teams, more education, more support from family members and community. So why, and ultimately we need a multidisciplinary approach to women's care, because no one person can treat, because it affects you from head to foot. Endocrinology, every endocrine hormones, it's from head to foot. So you need a nutritionist, endocrinologist, obstetrician, gynecologist, and primary care, mental health, and lifestyle therapist. So what happened to this young lady who has going through this? Well, she does not have any medical issues other than she gained 5 kgs in 1 year, despite regular exercise and fairly a good job. But the job is, good exercise, sedentary, 1,200 to 1,500 calories. She's already doing a multivitamins, vitamin D, fairly rich, a healthy diet. But family history is very strong for hypertension, diabetes, coronary artery disease, stroke, obesity, but negative for DVTs or cancers. So she underwent wellness checkup. Generally, everything was good other than dry vaginal. And her LDL was mildly elevated with a low HDL, and TGL also mildly elevated, with her A1C right at 5.8%, that is pre-diabetic range, even though fasting sugar was normal. But unfortunately, ultrasound also showed fatty liver grade 1. And physical exam shows a BMI is 30 with acanthosis nigricans and mid-abdominal obesity. So the decision was made not to proceed with menopausal hormonal treatment. Rather, she will try treating her vasomotor symptoms, insomnia, weight gain, and vaginal dryness. These are the most bothersome symptoms. So all this were added, including the phytoesterols rich diet as well as supplement. And one of the major thing was insomnia. So we recommended zolpidem with melatonin, and for uterus, strengthening of a uterus, and for urinary incontinence, Kegel's exercise was thought. And a trial of SNRI started and she was asked to come back in 3 months. So finally, I love this Indian Menopausal Society. Fit at 40, strong at 60, independent at 80. We need our women to be like this, otherwise we are in great problem. And thank you very much, Dr. Kumari, for giving me this opportunity to give this topic. Like you gave the topic for Dr. Prem Kumar, I understand. Only when you undergo something, you develop more empathy. Whether it makes me a better physician, I don't know. So this entire discussion was me. The case was me and is me still. So what I'm saying is it makes me more empathetic towards my patient. Compassion, I can now listen better when a menopausal woman is coming to me with hot flushes and tachycardia. I'm unable to sleep before I give the prescription. That's all we can do. Thank you.
I now request the chairperson to hand over the microphone to Dr. Thank you so much.